What's important is types of infarcts. We have already kind of discussed some of these, so we should be able to blast through this section. Again, we need to think about the layers of the heart. We have our fibrous pericardium, our visceral pericardium. This is the parietal layer, or also fibrous. This is the pericardial sac, or cavity. And then we have epicardium, myocardium, and endocardium. And this is the actual left ventricle, for example. What is the difference between transmural and subendocardial? A transmural, trans means all of it, throughout, the whole wall, right? A transmural infarct occurs from occluding the coronary artery at its root, and by root I mean before it gives off branches to perfuse these other layers under the epicardium. This is a big problem because there is no blood delivered to any layer of the heart wall, which is why it is called a transmural infarction. It involves the entire thickness of the heart wall. The high yield correlation with transmural infarcts for your brain to know all the time is that coronary artery vasospasm, aka Prince metal or variant angina, can be induced by cocaine, triptans, or tobacco. This leads to ST elevation, right? On your ECG, and Q waves, pathologic ones at that, not normal ones. They have to be pathologic because they're really deep. On the other hand, subendocardial infarcts are usually due to stenosis slowly limiting blood flow to the area of the heart last to receive blood. What layer directly under the endocardium is the last to be perfused? This segment here, which is called the subendocardium, right? It's under this endocardium. The endocardium receives blood via diffusion from whatever blood is in the left ventricle. That makes perfect sense, right? It's directly there. There's oxygen in it. There are nutrients in it. It just came back from the lungs. But the subendocardium, nope, it has to get its blood from these guys, sending its branches through the myocardium down to the last perfusing segment that reaches the subendocardium. This is the reason why subendocardial infarcts are not transmural, because it is the last segment that receives blood to get deprived of blood first. These have ST depression. I like to think about it as the subendocardium thinks it's sub or below par, and it's depressing to be below par. Now, another incredibly important part of the initial workup of performing an ECG is being able to localize the infarct. Why? Because it is an excellent way for question writers to incorporate anatomy into a vignette regarding the pathology of a myocardial infarction. Let's think about the ECG diagnosis of an MI. We have to do an ECG. Why do we do it? Well, we do it for a reason. Think about how the heart sits in the chest. So these are our four chambers, and this is our heart. And this is a CT of our heart. So think about it. If we cut this person like a bread loaf, and we are looking up from their toes to their head. In a CT, this is the left, and this is the right. So this is a rough drawing of a cross-section through the heart like you would see on a CT scan. Remember, CT scans view us like a bag of sliced bread from the toes up. This cross-section through the precordium is super important for you to visualize in your head. Now, what does precordium mean? Precordium is Latin for before the diaphragm. So, we are looking at a section through the thorax before the diaphragm. This makes a lot of sense why we call the leads we're about to discuss precordial leads. We are directly superior to the diaphragm in the thorax. The precordial leads are V1 through V6. They are positive leads placed directly on the chest wall, directly above the heart. The negative electrode is calculated using the center of the heart as the reference point. The main point here is that the precordial leads V1 through V6 view the electrical activity in a horizontal orientation, which is the Z-axis. So basically, it's looking at the heart like if you slice through it and you're staring directly at the slice of bread like you're looking at the crust. So for example, here's your slice of bread sitting on the table and you're looking at this little segment here. And then if you went up a little bit and you looked at that little segment, and this segmentation comprises how you look at the heart in this horizontal or Z plane. That's not that important. It's important to understand, but don't try to memorize that if you don't get it. What you need to know for sure for your test is what I'm about to tell you. So, again, where do these leads actually sit on the chest? V1 is placed here, V2 is placed here, V3, V4, V5, and V6 sits way out on the edge, on the lateral surface. As you can see, V1 through V4 are in rather close proximity to the left ventricle, right? See this? They're great at picking up anterior wall depolarizations, so they read the activity of the anterior wall of the left ventricle. Remember, they're reading the left ventricle because that is where the net electrical vector comes from in a normal heart. So if someone's suffering some sort of ischemia within the anterior wall of the left ventricle, you better believe you're going to see some weird stuff going on in V1 through V4. Now what about V1 and V2? Well, these are directly sitting, facing the anterior part of the interventricular septum. Which coronary artery supplies the anterior 2/3 of the interventricular septum? The left anterior descending. That is why any infarct in the septal perforating branches of the LAD will show up as ST changes in V1 and V2. So ST changes makes you think something about the septal branches that come off the left anterior descending. So if V1 through V4 are focusing on the anterior wall of the left ventricle, in addition to V1 and V2 specifically telling us information about the anterior 2/3 of the interventricular septum, what in the world are V4 through V6 going to be telling us? V4, V5, V6 are highly important for us to look at. The anterior lateral wall of the left ventricle, supplied simultaneously by the branches of the left circumflex and the left anterior descending. Remember, the left anterior descending sends marginal branches to meet the left circumflex in a lot of the population. So that is exactly what V4 through V6 will tell us. What is going on with that anterior left lateral ventricular wall? That is rather easy, right? Look here. It's the angry dad from the Justin Bieber concert with leads V1 through V6, V2, V3, V4, V5, V6 sitting right there on his precordium, his precordial chest wall. We are worried he may have suffered an infarct in the marginal branches of his LAD. So that means we need to look in which areas? V4 through V6. Again, because the left circumflex and the marginal branches of the LAD both supply the lateral segment of the left ventricular wall on the left side. Now what about limb leads 1, 2, and 3? Let's draw our heart axis on this image from our anatomy section. We definitely will be in a situation where our test question written by those board examiners will expect you to be able to combine the two in your mind. So if we draw our axis, and this is 1, this is another element, here goes another axis, and another one, and last but not least, there we go. Now which are these? So again, this is AVL in this direction. This is lead 1 with the positive electrode in that direction. This is our 0 degrees, remember? This is lead 2 in this direction. This is AVF, remember? VF for feet. This is lead 3 in this direction. And this is AVR, towards the right hand. So, we have drawn our axis directly on the heart so we can see how these leads are helpful in viewing the depolarization vectors created by each. Remember that the arrow at the end of each represents where the positive electrode is. So there's a positive electrode here, and that's our reading electrode. Positive electrode here, and that's our reading electrode. And that goes all the way around for all of these leads, which is important to know because a vector towards the arrow or the positive electrode, that means that you get a positive deflection. So a depolarization vector towards this arrow will be described like this, boom, up. And then when it comes back down to baseline, you have to come back down to baseline, and that's why you have a descent. So let's start with the inferior leads that are sitting below the left ventricle, which is AVF, 3, and 2. Remember, these are not in the horizontal plane directly above the heart, as they're not sitting in the precordium. That is what the precordial leads are for. Leads 3 and 2 both use the left foot as the positive electrode, so they are examining what is going on with the heart from an inferior view. I like to visualize each electrode of 2, 3, and AVF as a camera literally sitting on the left foot, looking up trying to take snapshots of the heart's electrical activity. It's like someone that's really, really short sitting at your feet trying to take pictures of your heart, right? Now what about AVF? It is basically the same, using the left foot as its positive electrode, except that it's augmented, which is why there's an A in the name of AVF, because the negative electrode is augmented, or a calculated average between the right and left hand. It doesn't have a tangible physical negative electrode. Again, not crucial for you to remember these specifics, but understanding is fundamental to answering questions on your Step 1 exam. So in summary, leads 2, 3, and AVF are cameras on the left foot looking up towards the heart, taking snapshots of the electrical activity and then scribbling it on your ECG paper. They tell you a lot about the inferior aspect of the heart. This makes sense, right? They're looking from way down here. They're like, hey, what's up? I'm looking all the way up at the heart from down at the feet. They are looking from underneath the heart. Now, which artery supplies the inferior aspect of the heart for the most part, for the majority? And that is the right coronary artery, right? So any inferior wall infarct, again, let me repeat that. Any inferior wall infarct will show up as some abnormality in leads 3, AVF, and 2, because they are created to view the electrical activity from the inferior view because they're taking snapshots from the feet. Now, let's look at leads 1 and AVL, these guys. They are great for examining the lateral wall of the left ventricle. Note how the left marginal artery coming off this left circumflex supplies the anterolateral wall. In addition, there are marginal branches not shown that come off of the left main coronary artery, and we want to give dual blood supply to that area. So again, we have the left marginal artery, which is coming off the left circumflex, and then we have our left anterior descending giving off these marginal branches to meet the left marginal artery that comes off of the left circumflex. Remember, both the LAD and the LCX come from the left main coronary artery. So, occlusion of the left main coronary artery up here would lead to a severe infarction because we lose the left circumflex, which supplies the lateral and posterior walls, and we lose the LAD, which supplies the anterior 2/3 of the interventricular septum, the anterior papillary muscle, and the anterior surface of the left ventricle. So occlusion of the left main coronary artery proximal to where both of the left circumflex and the LAD branch will show abnormalities in leads V1 through V6, 1, and AVL. Okay, great. Let's keep going and push on to the MI complications. We've already discussed a lot of these when we went through the evolution of a myocardial infarction, but it never hurts to hear something a lot of times. You always need to be worried about arrhythmias, right? Because hypoxia disrupts the sodium-potassium ATPase, and it leads to disruption of electrical membrane potentials due to disruption in ion concentrations. There's also the risk that we could potentially infarct some of the specialized conduction tissue. You can actually knock out the direct tissue itself, and this would obviously lead to some depolarization abnormalities. Now, cardiogenic shock is a rather simple concept. If a large segment of your myocardium dies, will it be able to contract? No. Your heart cannot pump sufficiently enough to the rest of your body, and you're now in a state of shock because all of your organs are being hypoperfused, including the coronary arteries within the epicardium. Whenever you have an infarct to the heart wall, you have to be concerned about either a complete or partial rupture of the myocardial wall. What are we worried about with a partial rupture? We're worried about a pseudoaneurysm because that is a partial rupture, right? It's not a rupture all the way through. We broke through the endocardium, we broke through the myocardium, so this is our endocardium, this is our myocardium. We broke through the visceral layer of our epicardium, and then there's just a tiny little bit of fibrous connections from the epicardium holding this false aneurysm together and allowing blood to accumulate in this space. So remember, a pseudoaneurysm is false because there is literally a hole in the endocardium, subendocardium, and myocardium that allows blood to leak into a sac lined by the fibrous epicardium. This is bad because the blood that collects within the pseudoaneurysm will be moving very slowly and can also form a clot. This clotting can set you up for an embolus because there's so much blood stasis within that area of ruptured myocardium. The ruptured myocardium will obviously significantly decrease your cardiac output as well. But if we completely blow through the endocardium, myocardium, and some of the epicardium, we can also start to pool blood in the pericardial space. So if we were to blow all the way through here, then we would start accumulating blood in the pericardium. And that is another potential risk of having an MI. If we have blown out this segment, instead of this just localized ballooning of a couple of fibrous strands holding everything together, we are now going to be diffusely filling the pericardial space with blood, and that is hemorrhagic cardiac tamponade. This puts a large amount of constrictive positive pressure around the entire heart. So this is a really terrible situation of tamponade. Now, what about time frame? 1 to 3 days post-MI, we should be concerned about neutrophils and fibrinous exudate extending into the pericardial space. So remember, the pericardium is just a layer of fibrous tissue on the outside, and then it folds on itself at the level of the great vessels. So here are the great vessels, and here's the heart. So right here at the great vessels, it folds over on itself because it doesn't include the great vessels. It's just around the heart. So there's a fibrous, and then this is the parietal layer, and then this is the visceral layer. Now, this is fibrinous exudate that can happen 1 to 3 days post-MI. What happens is that it is called fibrinous because fibrin will coat these two layers of pericardium. So there's fibrin coating each layer. These layers are facing each other. In combination with a large amount of protein, these two can start to rub against each other. There's friction between these two layers. And this creates a large amount of vibration. Remember, vibrations are just sound waves. And then when you put your stethoscope right here, you can hear these vibrations as sound waves traveling through a medium of the chest wall. So when you put your stethoscope on a patient's chest and you hear a friction rub, you hear the two layers of fibrin-coated visceral pericardium rubbing against fibrin-coated parietal pericardium. Now, another one keeps popping up on us, Dressler syndrome. You have to know this. High yield. It is a particular favorite, so make sure you know this. It is caused by undesired autoimmune response against specific cardiac antigens. This takes a couple of weeks because our immune system has to generate autoantibodies first. We covered this one rather extensively in the evolution of an MI.